how Medi-Cal is helping older and disabled Californians thrive in their communities. I'm Sandy Close, Director of Ethnic Media Services. EMS and California Black Media are partnering with the Department of Healthcare Services, DHCS, to present this sixth in a series of briefings about how Medi-Cal is transforming the delivery of healthcare services in California. DHCS is transforming Medi-Cal to ensure that Californians get the care they need to live healthier lives. It's worth noting 1 out of 3, approximately, residents of California are on Medi-Cal. Medi-Cal members have access to new and improved services to get well-rounded care that goes beyond the doctor's office or hospital and addresses all of their physical and mental health needs. These changes are part of a broad transformation of Medi-Cal to create a more coordinated, person-centered, and equitable health system that works for Californians. DHCS has expanded Medi-Cal, enabling more people to access vital community support services, including medically tailored meals, transportation to and from appointments, in-home care, and long-term care transition, helping people get out of institutions and back into their communities. Additionally, starting January 1st, 2024, assets like bank accounts, cash, property, and a second car are no longer included when deciding if you are eligible for Medi-Cal, helping more people qualify for coverage. For older adults and people with disabilities who are eligible for both Medi-Cal and Medicare, Medicare Medi-Cal Plans are now available in 12 counties in California that coordinate all benefits and services across both programs. For this briefing, DHCS leaders and community healthcare providers will share how Medi-Cal is helping more adults and older Californians live healthier lives at home. Speakers include Anastasia Dodson, Deputy Director of the Office of Medicare Innovation and Integration at DHCS. Dana Durham, Chief of Managed Care Quality and Monitoring Division at DHCS. Jenna LaPlante, Senior Director of Care Management Programs at the Institute on Aging, and 3 representatives from the Aging and Disability Resource Connection of Central and South LA, who include Carrie Madden, Program Director of ADRC, Keith Miller, Executive Director of their partner, CALIF, or Communities Actively Living Independent and Free, and Lily Sanchez, Case Manager at CALIF. We ask reporters to enter questions in the chat, and we ask speakers to monitor these questions and answer ones you feel are particularly relevant to your field of expertise throughout the conference. We'll send a video of today's briefing, plus expanded bios for each speaker later today. And we'll send video excerpts of the presentations early next week for use on your website or in social media. Now we welcome Dana Durham, Chief of Managed Care Quality and Monitoring Division, and Anastasia Dodson, Deputy Director of the Office of Medicare Innovation and Integration, both from DHCS, to give an overview of how Medi-Cal is transforming its services and eligibility limitations for older and disabled adults. We begin with Dana Durham. Please go forward.
Thank you, Sandy. Good morning or afternoon, I guess it is. As Sandy mentioned, my name is Dana Durham. I work in our managed care quality and monitoring division. And what our division does is we make sure that managed care plans or Medi-Cal managed care health plans provide high quality, accessible, and affordable services to Medi-Cal members. And we really appreciate you being here today, and we're going to talk about how DHCS is transforming or really innovating Medi-Cal to provide more supportive and culturally sensitive care that supports older Californians as well as people with disabilities. And so you may be asking yourself, why are we doing this and why should you care? Most importantly, it's really to make sure that individuals get preventive care and to help Medi-Cal members continue to be healthy and safe. Medi-Cal is providing services to help members avoid getting sick or having an accident, to help them from ending up in the emergency room or with a series of doctor visits. We're working to make sure that members have access to preventive, comprehensive services that meet their needs before they get sick. This is interconnected with what we talk about as social drivers of health. And that really is meeting people where they are, where they're born, where they live, where they learn, play, where they worship, and where they are in their community. The things that impact their health, their quality of life, and other things that are called risk factors, or what happens where they go about their daily living. We're working to transform medical to create a system that addresses the social drivers of health so that members can receive care in ways that are really coordinated to deal with where they are in every aspect of their lives. And really trying to make sure that we help where they are in their community and allow them to stay in the least restrictive setting possible. Now, there are a variety of services and programs that are available to help people. So today, I'll highlight just a few of the many changes we've made over the past several years. The first one I'll talk about is called Enhanced Care Management, or ECM, and its companion is called Community Supports. Together, they kind of are a foundational part of this transformation. These benefits and services provide coordinated access to care, more culturally competent care, better behavioral and physical health integration, and increased transparency. As a department, we know that historically the healthcare system has been difficult to navigate and it's sometimes isolating. And so what happens is that the quality of life for Medi-Cal members has really been kind of isolating and has had an effect on members and seniors and persons with disabilities, made it more difficult for those people to manage their severely complex and chronic health conditions. So imagine yourself, you've got all these things going on and you go into the system and you feel like you don't know what you're doing, and it feels even more isolating. So we brought in, as I said, ECM, or Enhanced Care Management, to make it where you have someone who helps you or comes alongside you to help you navigate the system. So ECM, or Enhanced Care Management, was introduced statewide in January of 2022, and it's available to eligible members with complex needs. Members are given a health risk assessment, or an easier way of saying that is someone helps ask you questions to know what's going on with you health-wise. And they're assigned a single lead care manager or someone who will help you navigate all of your health and health-related care and services. That's just, it sounds a little complex, but it's just someone who will be with you to help you understand what goes on and helps you navigate the system. So the scary system, they'll be with you, they'll ask you questions. They'll start by that health risk assessment that I talked about. So as that sounds a little overwhelming, but it really is just a way of reviewing your current health and identifying areas that you may need more assistance or less assistance. So they'll talk to you about mental health. Do you have things that you might need to talk to someone about? Do you have areas of substance use that you might need some help in navigating? Have you had chronic conditions? Do you have disabilities? Are there difficulties with your activities of daily living? Are you starting to have some dementia? And wants to make sure that you have the ability to know what's going on, and then you get to have some autonomy or get to make some informed decision. And this assessment is used to help an individual make their individualized care plan, and really is used to allow that individual to have their preferred setting. And it can be done in person, over the phone, or by mail. And the lead care manager will identify providers and arrange appointments. If you need help with transportation or you need referral to other services, that person will help customize that to the member's needs. And they're available to travel to meet with the Medi-Cal member where they are to help coordinate that care and treatment. So if the individual is homeless, they'll meet with them in a cafe or just on the street itself, but just somewhere that is easiest for the individual to meet with them. In addition to that enhanced level of case managers, we've added new providers that are available to assist disabled or older Californians. And we've added some that are more familiar or more able to help with specifically are more familiar to communities in general, such as Palmaturas. We've given them Palmaturas, or they may also be known as community health workers. And they help members navigate the complex health system to prevent and manage diseases, prolong life, promote physical and mental health and well-being, and connect people to the services that they need. And they're available to meet with people. Alongside
Dana,
those,
Dana, I have to ask you to
yes.
wrap up. Just sorry, but maybe make a final wrap up.
Sure. Along those, we also have community supports, and those things are like home safety modifications, medically tailored meals, and respite care. Those are just a few of the things that are available. But we have a lot of programs that are really to help someone navigate the system and really help them be able to live in the least restrictive setting possible. And with that, I will turn it back over to Sandy, who will turn it over to the next speaker.
Well, thank you. And I hate cutting you off because you've brought such understanding after the briefings we've had. A lot of the pieces fit together hearing you speak. So thank you so much. We go now to Anastasia Dodson, also with DHCS. Anastasia.
Thank you, Sandy. Thank you, Dana. My name is Anastasia Dodson, and I'm the Deputy Director for the Department of Healthcare Services, Office of Medicare Innovation and Integration. First, I want to talk about Medi-Cal and Medicare together. Medi-Cal is California's Medicaid program that provides comprehensive care for low-income Californians. Medicare is a federal program that is nationwide and provides health coverage to older adults and people with disabilities. People who are 65 and older, most of the time, will qualify for Medicare, and then people who are under 65, if they have certain long-term disabilities, they will qualify for Medicare. In California, there are about 6.6 million people that have Medicare. Of that 6.6 million, 1.6 million have both Medicare and Medi-Cal. We usually call those people who have both programs dually eligible or dual eligibles. People who have Medicare and Medi-Cal often have complex health conditions involving physical, behavioral health, or social needs. It's a great benefit to those folks to have access to both programs. It helps them afford their health care and access a wide range of benefits, including those that Dana was talking about. One thing I want to flag for you all is that some people with Medicare may not know they can also enroll in Medi-Cal if they meet the income limits for Medi-Cal. For people that only have Medicare, they can have co-pays or co-insurance that they have to pay when they visit the doctor. Medi-Cal works together with Medicare to cover those co-pays. Medi-Cal also works with Medicare to cover most of the costs of prescription drugs. Plus, there are other benefits in Medi-Cal that are not available in regular Medicare, such as long-term services and supports, dental, and other benefits that Dana discussed. Enrolling in both programs helps people receive affordable and accessible care. So for people enrolled in both, they likely will not pay for any care. We encourage anyone who has Medicare to also apply for Medi-Cal, and then if the individual meets the income limit for Medi-Cal, then they can get both. Next topic. How is DHCS supporting members with both Medicare and Medi-Cal to navigate benefits across both programs? We have something called Medicare Medi-Cal Plans, or Medi Plans. Those are for people with both Medicare and Medi-Cal, and it combines their benefits into one plan. Those Medi Plans coordinate all benefits across both programs. Medi Plans are available in a number of counties, 12 counties: Fresno, Kings, Los Angeles, Madera, Orange, Riverside, Sacramento, San Bernardino, San Diego, San Mateo, Santa Clara, and Tulare counties. That's an opportunity for about 2/3 of people who are dually eligible in California to enroll in one plan for both benefits. In 2026, those Medi plans will be available throughout the state. Another topic I want to talk about is the elimination of the asset limit for Medi-Cal. That means any amount of assets in a bank account, a second car, etc., does not impact Medi-Cal eligibility. Only income and household size affects Medi-Cal eligibility, and that change was made in January 2024. We have also made changes to Medi-Cal estate recovery to help Medi-Cal members. Basically, the Medi-Cal estate recovery program seeks repayment from certain Medi-Cal members after they pass away. That only applies to certain benefits and only applies to certain benefits that members received after they turned age 55. And that only applies to assets that need to go through the formal probate process. If a deceased Medi-Cal beneficiary owns nothing when they pass away, nothing will be owed to the state. We want to emphasize that estate recovery does not affect everyone. It is only limited to those who are age 55 and older, who receive nursing facility services or certain home and community-based services. And again, that's only for people that their estates need to go through a formal probate process and who owned assets. There are many exceptions and hardship provisions, and most Medi-Cal members' estates and heirs will own nothing. We will put a link in the chat around that. The last thing I want to cover is that we have made big transitions in our healthcare delivery system in Medi-Cal by enrolling almost all Medi-Cal members into a Medi-Cal managed care plan. We partner with 23 managed care plans in the state, and by transitioning members to Medi-Cal managed care plans, we are standardizing the benefits and services offered to all areas of the state. And that means no matter where people are in California, or if they move from one county to another, they can get the same services. Also, no matter what plan they are enrolled in, each plan will provide access to care that's needed. That includes community supports, enhanced care management, or preventive services with interpreter services. As we keep improving Medi-Cal, we urge all eligible Californians to make the most of their Medi-Cal and Medicare benefits. Our goal is to make healthcare more fair, more efficient, and focused on members' needs. Thank you.
Thank you both. This was extraordinarily helpful. It is an extremely complicated healthcare system, and it feels as if the transformation of Medi-Cal could actually have an effect on the entire healthcare system. Our first question from our media on the call relates to that. Is there a way that these expanded and transformed services are affecting how healthcare delivery for all Californians or for more Californians who don't qualify for Medi-Cal will receive care in the future? And I would ask you both to answer that. Maybe Dana, you go first.
Sure. I mean, I think that we as a community are looking at adding different providers to the caring community overall. Community health workers and promoters have not been paid always. And as a state, we're looking at adding those as formal providers and training requirements for community health workers, as well as making sure that community health workers are very valued and formalized as part of the healthcare community, which they have always been very valued, but making sure that they're recognized and really reimbursed for the value they bring. So we're really proud of that.
That's great. And Anastasia, the the whole vision of healthcare seems to be under a transformation. It's not just going to the hospital. It's not just seeing the doctor. It's about health in community. Could you just say one or two things about the overall impact your work is having on healthcare in California?
Sure. Well, for example, people with Alzheimer's or related dementia, the individuals themselves, the patients, they may be getting care through Medicare. Also, they can get services and supports through Medi-Cal, and their caregivers, they can get respite care through Medi-Cal. And that coordination across both programs for that population is a good example of how that transformation can work for other populations, such as people that have behavioral health needs that touch upon multiple delivery systems. What we're trying to do is have the delivery systems, including local community-based organizations, talk to each other and collaborate on care.
Thank you. Because of time constraints, we're going to go to our next speaker, but please look at the questions on the chat, a number you may want to answer during the conference. So we go now to Jenna LaPlante from the Institute on Aging for an overview of how the Institute has transitioned from their existing services to these new Medi-Cal programs over the last 2 years. Ms. LaPlante, thank you.
Hello, everybody, and thanks for having me today. So I would like to talk about the fact that here at Institute on Aging, we had been serving Medi-Cal recipients in a similar manner prior to the Medi-Cal changes in 2022 across 3 counties in the Bay Area. We were serving adults with disabilities who were either living in a nursing facility and wished to transition to the community, or those who were in the community at risk of going into a nursing facility who did not want to. Our goal, like our folks from DHCS were saying, in line with our current changes, is to maintain people in the least restrictive environment that they choose to be in. We were able to transition our existing clients because we were working with some of those Medi-Cal managed care plans to the new Medi-Cal services pretty seamlessly on the surface to them. We'd had to do a lot of work behind the scenes, right, in order to make it work for us in terms of billing and program structure. But in terms of the actual services that individuals were receiving, they were able to maintain the same case managers and maintain the same services. What we were providing was care coordination, which would connect people to community resources such as doctors, meals, caregivers, transportation. And in some cases, we also had some additional money to provide temporary gap coverage for areas of need, such as support for maybe a residential care facility or temporary caregiving while someone was working on getting on in-home supportive services for the long run. Those services are in line with enhanced care management and community supports with what is being offered right now. So now we're serving clients in 9 counties across the state through both care coordination, enhanced care management, and community supports. The counties we currently serve are San Francisco, San Mateo, Santa Clara, Santa Cruz, Monterey, Merced, Alameda, Riverside, and San Bernardino. We are in talks with several other health plans across the state to look to expand our services. This has allowed us to serve more people than we ever served, and we're very excited about that. Our goal is to serve adults who have been historically underserved. And what we're doing in order to really best practice serving communities who have been underserved is ensuring that we hire bilingual, bicultural staff who reflect the demographics. When we receive eligibility lists from our health plan partners or we just generally look at the demographics of a community that we're serving, we target hiring staff that meet that community. An example that we frequently use is that there is a large Vietnamese population in San Jose and Santa Clara County. And we had not historically been finding a lot of folks from that community really engaging in our services. We hired a Vietnamese speaking care manager who went out to community centers, and all of a sudden we got a huge influx of folks from that community. And then we were able to hire a couple more care managers who spoke Vietnamese, as well as an outreach staff person who can then go and meet the community's needs the best, which then, through word of mouth, then increases the referrals because people are like, hey, they're able to, provide culturally competent services to us. And so we do that everywhere we go. We just started in Merced County, and we noticed that the vast majority of the eligible members are Spanish speaking. So every job we've posted has been for Spanish speaking staff. We will, of course, use interpretation services as needed for languages that, maybe don't meet threshold, for like high enough amount of people for us to hire someone bilingual. But we are always targeting having bilingual and bicultural staff. The other thing that we're doing, and this was previously mentioned, is we are looking and we hire community health workers. Community health workers vary from lead care managers a little bit because they are actually members of the community being served, right? And the idea is to even further be able to engage and connect with those community members so that they are accessing services. I mean, as we all know, historically underserved communities have been that way due to large amounts of, systemic discrimination, as well as, distrust of systems. So our goal is to have providers available that help people engage with the benefits that they are eligible for. At this moment, we are offering care coordination in all of those counties I mentioned. That's enhanced care management. The community supports piece is not available in every county. There's certain community supports that are and certain community supports that aren't. So in some counties, we're providing some money to help support residential care facility placement for those who are low income as a step down from a nursing facility. So people who might need a lot of caregiving, perhaps 24-hour oversight, but they don't need to be in a nursing facility where they're getting nursing or rehabilitation care. They just need some support to live in the community. Those types of facilities historically have cost, $5,000 to $10,000 and have been out of reach for folks who are Medi-Cal eligible. In certain communities, we do have some additional funding to help support those placements with the person putting some of their Social Security money towards it. We also have contracts in some of our communities to help support first month's rent and security deposit for people who we are helping navigate and find housing for, because obviously that's a huge amount of money that then makes it prohibitive to actually move into housing once you are able to locate it. We also, in some communities, have funding to do what we call environmental or home modifications. We have an occupational therapist on staff who will go into people's homes and say like, hey, you want to stay at home, but you can't use your bathroom anymore because now you're in a wheelchair and you can't get in there, right? So we can do things like put in grab bars, in ramps, and sometimes even widen doorways so that people can remain in their home that they've been living in for years, but has now become inaccessible for them. Something that I did want to mention is that given that these services do go through the Medi-Cal managed care plans, they need to be authorized by the managed care plan that the person is a member of. So the referrals tend to need to go through the care plans. A lot of the members can call their member services for their care plan on their managed care plan, and then they will authorize them and send them to us. But honestly, in order to decrease confusion, and honestly, the word I just like to use the most is really bureaucracy, which is really like one of the challenges in navigating, right, the system. People can call our main line and we can help. We have outreach coordinators who can help kind of support getting people into the services and eligible for the services through their managed care plan.
That's an amazing overview of how this is operating on the ground. Are you able to tell us roughly how many people you think you serve in these now 9 counties? And what are we looking at as Californians grow older and the aging population expands?
So we actually just did this for as of the end of June to wrap up kind of what we call like our fiscal year, right? So it just goes from July to June. And we are currently actively serving 1,000 Medi-Cal members across the 9 counties with our programs that we have. We are in talks with many other health plans, and we also just are well aware that even though this is an eligible benefit, the health plans are still working on rolling it out, right? And they need more providers, community-based organizations. So our goal is to continue to grow and expand these programs rapidly. We are having what we've been doing is staffing ahead of time, right? So we reach like a certain amount of members that we serve, and then we say, hey, we got to hire someone else so that we can continue to serve people. And we just keep doing that so that we can grow and grow in these communities and reach the underserved populations.
When you talk about being able to provide first month's rent, for example, to help somebody transition back into the community or who was unhoused, normally we wouldn't think of that as part of healthcare.
Yes.
So just a final word on that. Jenna, this is philosophically a real re-evaluation and redefinition of what it means to lead a healthy life and what the responsibilities are of healthcare providers. Could you just briefly summarize that, and then we'll go to our final speakers?
Yes, I will say this is something I'm personally super excited about. I am a social worker by training, and my whole life career training has been about biopsychosocial. So all aspects of someone's health, not just the medical, right? And under this new Medi-Cal change, as Dana and Anastasia were talking about, the goal is to use these historically earmarked for just medical funding dollars to address what we call social determinants of health. That's just a fancy way of saying housing and mental health and, historical oppressions and all of those things. And now we're able to access money to support those areas that we all know there's been an abundance of research over the years that show that those impact long-term medical health outcomes, right? So the goal is to use these dollars that were just used to be for medical expenses to address these larger issues.
Well, thank you. And please, all of you stay on for our final Q&A session, but we'll go now to our fourth presentation, which comes from the Aging and Disability Resource Connection of Central and South LA. And Carrie Madden is the program director of ADRC and will be the first of three people who'll talk very similar, I think, to Jenna's presentation about what this transformed Medi-Cal services mean in terms of your work for older adults and people with disabilities. Carrie, thank you for joining us. Please go first.
Okay, thank you very much. So the ADRC is the Aging and Disability Resource Connection. One of our core partners is 211 LA, and they are a phone center where they pre-screen calls for us to find individuals with disabilities and older adults. And so what happens is they'll send us a referral list and we'll call back those consumers to find out what their needs are. Our system is considered a no wrong door system. So basically everybody who calls will get some sort of referral. It's very rare that we cannot assist them. Our core services, our first core services is information and referral enhanced. And the enhancement is that it's two parts. One is a warm handoff. So while we're creating case notes about the consumer and their issues that they're calling about, we can forward those case notes to the providers of the services that they are looking for. So we give a warm handoff so that the case providers start off knowing already about what the caller's problems are. And the second part of the enhancement is that we do follow-ups. So once we've given them the information about the services that they are inquiring about, we'll call back in a few days to make sure they actually made that connection so that it's more seamless, that they don't fall through the cracks. So that's the first one. The second one is options counseling. A lot of times we'll get a call in and a person will already have an idea of the service they want and maybe a name of a program they want. But in reality, once you start talking with them and giving them options and finding out their abilities, we find that maybe there are programs out there that are better suited for them. So we'll give them not only the name of the program that they were inquiring about to begin with, but we will give them the information about the other programs they didn't know about. The third service is a coordination of services. And how this takes place is a lot of times we get calls from individuals that are homeless. And when we speak with them, we find out they need a lot more than just finding a place to live. A lot of them have no income. A lot of them have no food. Sometimes they need a wheelchair. So what we'll do is we'll go ahead and refer all those services to them. And then we'll follow up and make sure each individual service has been provided. And finally is our transitional service. And the transitional is when we help people come out of nursing homes, treatment facilities, and we give them the services that they need to continue to live back in the community they came from. Thank you.
And just a very quick final note, Medi-Cal Transformed Services under CalAIM has enabled you to expand this operation. Just quickly, how has Medi-Cal Transformed Services affect this work?
Right. Okay. So Medi-Cal, with Medi-Cal now, some of the services are quicker. Like we've had individuals who've called that are homeless, and now we find out that working with their doctors, their social workers, we can get them housed quicker than before. The process is very long without that Medi-Cal connection. But now that the connection is there, I'm seeing the individuals receive services faster.
I see. And let's go to your partner now, Mr. Keith Miller, who will take us a little deeper into the impact of the Medi-Cal expanded services. Thank you, Mr. Miller.
And thank you, Sandy, for having CalLife be involved in this. It's great. And thank you, Carrie, for the overview of the ADRC. So my name is Keith Miller. I'm the Executive Director of CalLife, Community Actively Living Independently and Free, and we're located in Los Angeles. We are one of 28 independent living centers in California and work with people with disabilities and older adults. Recently, we entered a contract with one of the HMOs under the CalAIMS program to provide community support services for high utilizers and individuals entering the emergency rooms. Under this program, we provide community support services such as housing retention, housing stabilization, and ongoing support and case management services. Funding for these services are paid by Medi-Cal and reimbursed with a fee for service. CalAIMS is a program is set up to help people with disabilities and seniors to connect with agencies once they are discharged from a hospital and provide ongoing support. The CalAIMS program is a pilot program in the state of California and uses Medi-Cal dollars to pay for direct services. It also helps an individual to access additional services that are not paid by Medi-Cal. At CalLife, 51% of the staff who work here are people with disabilities and provide direct services that are not covered by Medi-Cal. Services that we provide are benefits assistance, assistive technology, transitional service from nursing homes, diversion services, transitional youth services, helping individuals, youth who have disabilities who are transitioning from high school to enter either college or the workforce. We provide peer counseling. We do systems change advocacy on a federal, state, and local level. We work on the ADA, and we provide support for people in areas that are experiencing disasters. We work closely with the Department of Rehabilitation, the state, the county, and city, along with several other community partners. The only criteria to receive services at CalLife is that you're a person with a disability and you could benefit from our services.
So now we go to one of your colleagues, Lily Sanchez, who can talk about the difference expanding these services through Medi-Cal has the impact this has had on a particular consumer. So Lily, please share your story with us.
Hi, good afternoon, everyone. My name is Lily Sanchez, and I manage the programs at CalLife, Direct Services. What we do for our consumers is we do the legwork for them. As Keith was mentioning, part of the Independent Living Center, we do have a variation of services that range from assisting a person be housed or maintain their housing, assisting a person with obtaining their benefits, or assisting a person with assistive technology. And all of that is in-house. So with that, these are fundamental services that a person requires or needs, especially when they are vulnerable state. Part of the Independent Living Center, we also help with keeping people away from institutions, away from being institutionalized in a nursing home facility, given that we work specifically with people with disabilities and seniors in that category. I will share with you the story of one one consumer that was referred through Molina Care. One of the social workers contacted our benefits department, and this person was high risk. He was high risk to entering a nursing home. And through our services, we were able to prevent that. When that person came to us, the person didn't have in-home support services. The person was not able to go into the community and get their California ID. The person that was not able to commute or transport himself to the necessary places in order for him to get the services that he needed. So through our center, and through our advocates, we were able to do the legwork for him. We were able to do the paperwork for we were able to provide the services that the social worker at the HMO could not. And through those services, we coordinated our services with the HMO, with the managed care. They managed the medical part, we managed the social part. And because of that coordination of care that transpired throughout the services for this gentleman, he is currently housed. He has in-home support services. He has food that will nurture him and give him strength in order for him to stop utilizing the emergency room as highly as he was before he had all these services in place. So bottom line, the foundation starts with the core services that we house in the Independent Living Center. And this is how it is important for the person who has that Medi-Cal and who needs those services connect with CBOs just like ours so we can incorporate those services for the individual.
Thank you. Thank you to our three final speakers who split a single position so we could hear your three perspectives. Thank you so much. We're now going to open the conference to Q&A. And one of the questions which we'll go back to Anastasia and Dana for is looking at the tremendous change, that the transformation you're envisioning. What do you think as of now are your greatest success, and what is the greatest challenge moving forward for this transformation of services for elders and people with disabilities? Could we start with you, Anastasia?
Sure, thank you. One of the greatest successes, I think, is that collaboration with local community-based organizations, as you've seen. So people who know their communities, know the local service providers, hospitals, health systems, and can work effectively. So we're really proud of that.
And what would you say is the biggest challenge? I mean, in part, how many people who qualify for Medi-Cal know about these expanded services, who fit the older adult people with disability qualifications?
Right. There certainly is more work to do, and to build awareness and to build the right referral and enrollment processes. And I think, again, local folks will probably echo that we need to make sure that we've got all the communication channels lined up, and it's at the local level. But we do want to do whatever we can at the state level to build those bridges. And Dana may have more to offer on that.
Dana, please, what do you consider the biggest success so far of the work you've been doing and your greatest challenge?
That's a great question. They're always one and the same, aren't they? I mean,
Yes.
I think part of it is you're trying to build up those local connections, but as you build up those local connections and try to keep people more in the community, it's that as you begin those local connections, you try to build up the community, you continue to find different ways to do that and have those conversations. They become harder. How do you get more of the community involved? How do you get people who understand the community to be to find a place at the table? If you're in a community who serves who's Hmong, how do you make sure that those who understand what it's like to be Hmong have a voice that's heard, and understand what that means? If you're in a community that really values a religious perspective, how do you know that voice is really there and understand what that means without taking that value and overlaying it for everyone? So how are you sensitive to that without making sure it's a value that everyone has? And I think navigating that with sensitivity and making sure the voices are heard in equal parts is one that we really want to make sure is there. And it's hard to do that.
Let me ask Jenna LaPlante a follow-up question, and thank you for your response. Jenna, after many years in this field, to what extent do you see California breaking ground for the rest of the country through what it's doing through transformed Medi-Cal services, especially as the country ages and the whole idea of age being the dominant issue now on the news curve is both, it's a double-edged sword in a bit, but I'm just curious, are we looking at California once again leading the way in this field?
I mean, in my experience, the answer is yes. I've worked in several states. I've worked in Massachusetts, Vermont, and California. And I will say that, generally Medi-Cal, Medicaid, right? Each state has the option to apply to the federal government to waive how they use the dollars for more than just medical services. And some states do that and some states do not. It's kind of like under, the Affordable Care Act, some states chose to expand it and some states chose to not, right? But as there are other states that offer home and community-based services through Medi-Cal or Medicaid in the other states. But of course, here in California, we are always at the forefront of innovation, and this recent expansion to really use these Medi-Cal dollars for social determinants of health is just incredibly novel. I mean, I don't see anywhere else, right, that they're actually using Medi-Cal dollars for first month's rent and security deposit, things like that. And our focus here too on really ensuring that we are providing culturally responsive services to underrepresented communities, given that we are such a vast and diverse state, is really also just at the forefront of innovation across the country, as far as I have seen.
Well, thank you. And finally, to Carrie, Keith, and Lily, what would you say is the biggest way that Medi-Cal transformed services for older adults and people with disabilities has helped you accomplish what you wouldn't otherwise have been able to accomplish? Carrie.
I think the one of the key is funding. Funding, as Jenna was saying. What we have experienced in the past with our clientele is that there's very little to non-existent funding for first month's rent and deposits. And that's very key. That has been very, very key in assisting our consumers who have that Medi-Cal aid.
And I'll just add real quick, Sandy.
Yes.
We're in Los Angeles, and we see a very large homeless population here. And we see things that no one should ever see here. So this reform that we're seeing, first month's deposit, working with the HMOs, and having it connect with social service agency is very important.
Well, and Lily, what would you say is the biggest difference for you in your work directly with people through the expanded Medi-Cal services?
The education part, educating them in lay terms. A lot of times our clientele don't understand the terminology and the lingo that is coming down from the centers of Medicaid, and informing them and giving them the information in lay terms and letting them know that there are services that they could obtain through having Medi-Cal services.
Terrific. You've been a terrific panel. I have one last request. We in journalism rely on headlines to help draw audiences to our stories. I'm going to ask each of you for your suggestion of a headline about the impact of the transformation of Medi-Cal services. I almost want to say, why am I on the healthcare plan I'm on? Why aren't I on Medi-Cal? But with that in mind, what headline would you like us as publications and broadcast outlets and online outlets reaching a very diverse population? What is your headline for today's briefing? And we'll start with you, Anastasia. Don't think too hard, just off the top of your
Yeah. People who have Medicare can qualify for Medi-Cal also, and it helps them to afford their Medicare benefits.
Okay, very good. And Dana, what about you? What's the headline for you?
It's that healthcare should be personal and you should be able to stay in your community. And that's what Medi-Cal should be for you. And that's what we want it to be. So
Those are very inspiring. I will go next to Jenna. What's your headline, Jenna?
I think I would say, Medi-Cal has now expanded to cover non-medical services and community resources that it did not previously, something to that effect, so that people know they can use Medi-Cal for other things than just their doctor's visit.
Terrific. And very quickly, Carrie, Keith, and I'm putting you on the spot, Lily. Very simple headline. What do you want your audience to know?
Okay, go ahead.
Two.
We have two.
Okay. Medi-Cal is helping move people off of the streets.
Okay, terrific. Maybe that works for all three of you, but Keith?
No, Lily has one, so I'll let her go.
I think my blurb would be Medi-Cal. Now, Medi-Cal social services hand in hand.
Oh, very, very good. Keith, can you top that?
I cannot top that. I will take the lead.
Okay. You were very good sports. I want to thank my colleagues in ethnic media, but above all, I want to thank Department of Healthcare Services. You have given us the opportunity to look through 6 briefings at what may be the most historic transformation of healthcare delivery and understanding what healthy lives require. A lot of us think about terms like social determinants of health, and honestly, it's hard for us to necessarily understand what that means. Today's briefing has really brought that home to us, and the combination of the 6 briefings, I salute DHCS for your investment in ethnic media as a critical way to get information out to communities that may not have the grasp of this historic transformation and what it could mean for them and their loved ones. Thank you so much. This conference is now adjourned.